So we have another speaker lined up. In fact, it happens to be the president of the United Physicians and Surgeons of America, who's an orthopedic surgeon who you met over the course of the conference, I believe daily, Dr. Daniel Craviotto. He's a board-certified orthopedic surgeon who practices in Santa Barbara, California. He received a medical degree from the Medical College of Wisconsin in 1985. He's a fellow of the American Academy of Orthopedic Surgeons and a member of the American Association of Hip and Knee Surgeons. He's been practicing since 1991. He's authored several publications, including A Doctor's Declaration of Independence, it was in the Wall Street Journal. And in 2014, he was named the president of the United Physicians and Surgeons of America, and he's one of the people who brought this course that you're enjoying and hopefully learning from and being able to take action because of it. So Dr. Craviotto is going to present the doctor-patient relationship versus the legislation of healthcare in America. Dr. Craviotto?
Thank you so much, Craig. You know, sometimes timing is everything in life, and that was a perfect segue discussion for my presentation. So good to be here with everyone here this morning live, and then all of you watching. Before I get into my talk, let me just share a little bit about myself, because I think it's important when we're talking about healthcare policy. All of us are from different clinical situations. So I am an orthopedic surgeon. I'm 59 years old. I am in Santa Barbara, California. Santa Barbara, California is a population of about 100,000. The county, Santa Barbara County, is about 150,000. There are 28 orthopedic surgeons in Santa Barbara. There are 300 physicians in Santa Barbara. The multi-specialty clinic we have in Santa Barbara is 150 physicians. So 150 multi-specialty physicians, 150 private physicians. And that multi-specialty clinic, it looks like, is going to merge with a single hospital in town. The FTC has been looking at it for a year. From my particular standpoint, it doesn't pass the sniff test. But that's what I'm faced with as an independent physician. I share that because I think as we all make, decisions as physicians about what we're going to do, they're not all going to be the same, because what my situation is in my community will be different than yours. So I just wanted to share that now you know the perspective I come from. I am not, and the other thing I will share with you, I am not a healthcare policy expert. I am not a healthcare economics expert. I am a physician in a community, and the only thing I can speak to with some expertise, I believe, are the changes, the impact that some of these changes have on me as a physician, as an orthopedic surgeon in Santa Barbara, California. And that is my expertise. So I entitled my talk, The Doctor-Patient Relationship versus the Legislation of Healthcare in America. And don't miss that. Don't skip over that. That was intentional. Versus. Versus means as if something is threatening that relationship. As if something is competing with that relationship. So the title is intentional. So I wrote this op-ed in the Wall Street Journal about a year ago. And it was a process. For me, it involves some emotion and some frustration and anger, and I was just amazed at the outpouring of response. And honestly, I'm thinking, I'm little Danny Craviotto. I'm in this small community. I'm just a small community physician, and I was just amazed at 8 to 10 letters coming in every day, and phone calls from physicians on my voicemail message coming in every day, and emails coming in every day, and they all said the same thing. You said what we kind of feel, and thank you for doing that, but really, I can't even begin to explain that. I said, well, why did that happen? And so, yeah, I didn't think I'd be able to read the words there from here. I'm a 59-year-old guy with reading glasses, but so I just wanted to share this. Words are powerful, right? And spoken words are even more powerful. So if you permit me, I just want to speak this, if I could bring myself to the same context that I felt it when I wrote it, because I really think spoken words are powerful. I can't read off that. Maybe I can. I'm going to take, if the camera follows me here. my 23 years as a practicing physician, I've learned that the only thing that matters is the doctor-patient relationship. How we interact and treat our patients is the practice of medicine. I had these letters come in, I was kind of confronted, kind of convicted, and my overriding thought was, why me? Why didn't someone in one of our medical organizations speak those words? Because, unless I'm wrong, but I don't think I am, it was felt by every physician in the United States. So why didn't someone in one of our medical organizations speak those words? That might be hard for some people here to hear that, and I might be way off base. As I said, I look at things from my perspective, but why didn't someone from the Mayo Clinic speak those words? Why was it me? I mean, I'll let your answer, I think, the answer you come to in your own mind, might be the reason we're in the predicament we are today. I just want to share that with you. So we talk about a lot about the doctor-patient relationship, and whether you call it the physician-patient relationship or the patient-physician relationship, to me it's the same thing, and I understand the emphasis of rewording it, but it's about the patient comes first, and what can I do my best for the patient. So we talk a lot about it. I love this Norman Rockwell painting, because whatever it is, whatever the doctor-patient relationship is, he communicates it beautifully. Doctor at the bedside. There's human touch there. They both have a look of concern. Sitting down, doctor's bag is there. And I think he beautifully paints that, the doctor-patient relationship. And really the reason I like it is it brings me back to a time of glass thermometers. So we talk about it, but I took my stab at trying to define it. And you probably have things you could put to, but these are my words. Well, certainly build on trust. It takes time to develop. Eye-to-eye contact, and I mean really eye-to-eye contact. A listening ear, and I mean really a listening ear. It's easy for any of us to get distracted. I'm running behind in the office, whatever. Sometimes I have to remind myself of that and sit down and really, really listen. It certainly involves physical examination and the importance of touch. It is very personal sharing by the patient. Our patients tell us things about any body parts and they share it. People don't do that to anyone in society. And in the end, in my opinion, one way to define it, it is one human being, the patient, permitting another human being, the doctor, to poke, to prod, and to examine their body for the purpose of restoring health. That is the doctor-patient relationship. Two people in one exam room. But now we have this triad, you see. Now we have the doctor, the patient, and the computer. And I'm not against the computer. In fact, I love it. I can check electronic records from home. I have digital x-ray. So I like it. I think it's going to be improved as we go forward, and there's some things we can do to make it better. But so I'm not against it at all. But a few questions for all of us, myself included. Am I looking at the patient or my computer screen? What is the first thing I do when I walk into the exam room? Am I clicking boxes on a template, or am I truly engaging and listening to the patient? Did I make physical contact with the patient? Did I examine the patient? And perhaps most important of all, would I want to be engaged that way by my doctor if I was the patient? 1981, first-year medical student, we read a book called Bedside Diagnostic Examination by DeGowan and DeGowan. I see some nods in the room. It was a great book, actually. I really enjoyed that book. Taught me kind of how to be a doctor when I was a first-year medical student. But, quote, present to the patient the appearance of being unhurried, interested, and sympathetic to obtain his confidence and rapport. And second, write sparingly while the patient talks. And I suppose these days we could say click sparingly while the patient talks. I kind of researched this topic and looked for articles and to people who looked at this and researched what difference does it make when the computer's in the room. Here's some quotes. When doctors spend that much time looking at the computer, it can be difficult for patients to get their attention. We found that physician-patient eye gaze patterns are different during a visit in which electronic records, in which electronic health records versus a paper chart are used. Not only does the doctor spend less time looking at the patient almost always looks at the computer screen, whether or not the patient can see or understand what is on the screen. So the question is, for all of us, well, who are we listening to? Everyone in this room knows that, but let me just knows this information about the HITECH Act, but just for the purposes of my talk, wouldn't hurt to review a little bit. HITECH Act, the Health Information Technology for Economic and Clinical Health Act. So the question is, for all of us, $155 billion, part of the American Recovery and Reinvestment Act of 2009. The Department of Health and Human Services was instructed to spend approximately $26 billion to promote and expand the adoption of health information technology in the electronic health record. Physicians who do not adopt an EHR by 2015 will be penalized 1% of Medicare payments, increasing to 3% over 3 years. It was the idea that using technology to facilitate the free exchange of health information and delivery of health care in the United States. Broader EHR use is a way to get healthcare costs under control and to achieve significant improvements in care and to start improving outcomes. HITECH proposes the meaningful use of interoperable electronic health records throughout the United States healthcare delivery system as a critical national goal. And here's what it's all about. You need data and information to do population health management. The IT person in charge of the the HITECH Act, I read some of this stuff, and they freely admit that, you can be a great doctor and you can have a great doctor-patient relationship with a paper chart. Everyone admits that. But this is what it comes down to. They want access to information, and they need data and information to make wise decisions regarding population health management. I don't disagree with that. There's some issues perhaps with it, but I don't disagree with it per se. Meaningful use. Well, the idea was that you can't just have a computer in your office. You have to use it in a meaningful way. Well, what is that? To improve care coordination, to reduce healthcare disparities, to engage patients and their families, to improve population and public health, and to ensure adequate privacy and security. I need to step over here. I didn't realize this was going to be so small. So I'm an orthopedic surgeon. I'll pick on my own field, okay? I have some questions. Is a 5-page report by the orthopedic surgeon better than a 1-page report? Is that improvement in care and quality? Should orthopedic surgeons be required to take and document blood pressures and heart rates? Because the HITECH Act mandates that. I never did that as an orthopedic surgeon before this. So the orthopedic surgeon, in a 6-page note, is commenting on jugular venous pressure and 2+ carotid pulse. Really? Really? The orthopedic surgeon is going to examine that? Don't think so. But do I really believe that the physician did all that he or she documented? A 5 or 6 or 7 page report would imply probably a 60-minute office visit, or only 4 patients seen in an afternoon. That 5-page report has led to note bloat in our medical records, and some of them are 8 pages, where it is difficult to locate and focus on the pertinent information. So what are we doing here? I mean, really, what are we doing? Are we playing a game to not get audited? Is it a means for us to upcode? I see people upcode all the time, and physicians better start. We need to rein in our own house in order too. So, medical documentation. What was the original purpose of medical documentation and the medical chart? Well, I've only been practicing for 30 years, but I suspect before that, it was simply so that the physician would have a record where he could look back, or she look back, and say, oh, when I saw that patient 2 years ago, that's right. They had a little shortness of breath. I listened to their lungs. They had some RALs. I started on some Lasix. That was my treatment plan. That was it. To jog your memory, I suppose. I think that's all it was. What has it become? A record where every word is challenged by an auditor or attorney? And is there a better way? Well, we're about solutions here. Dr. David Mann and I suppose others have spoken eloquently about this. We need to decouple billing from E&R documentation. And I know there are powerful forces at work in terms of coding and other things, but if we just did that one thing, if we were to decouple billing from documentation, in a moment, we would get rid of note bloat, we would discourage upcoding, and we would get back to a day when the physician only documented what was pertinent. Dr. Mann, and I liked his idea, I think he only proposed one code, but I say why not just have 2 codes? A new patient code and a follow-up code. And instead of documenting based on what's in the medical, instead of what's based in the medical record, that encourages all this, can't we just have an honest discussion and say, look, we know orthopedic surgeons and the nature of an orthopedic surgery practice. You spend on average 10 to 15 minutes with a patient. We know that. So let's just come up with a reasonable fee. I'm talking about Medicare. You know, those who have direct to patient, that's a different thing. And perhaps that fee, these are arbitrary numbers, perhaps that fee is $100 or $125 or whatever for a new patient. A follow-up patient would be different. On the other hand, we know if you're a cardiologist or a pulmonologist or an intensivist or a primary care physician, you're going to spend an hour with the patient. Can't we have a reasonable discussion? What's an hour? Maybe they get paid $200 for the new patient or $250. I don't know. We can surely have that discussion in a reasonable way. Document only what is needed, but be reimbursed for average time spent with a patient in your specialty field. The problem: time spent in front of the computer doing data entry takes away from time spent with the patient. In this day and age where we are supposed to be more efficient, we have become less efficient. In fact, one commentator said there are approximately 20,000 scribes working in the U.S. right now. And some people have said that having scribes is a way to get around this EHR usability. It's not perfect. It's not efficient. And perhaps having scribes is delaying the development of better systems. But that commentator said, and I think this is interesting, only in healthcare can you have a computer and still hire one more full-time equivalent. Think about it. What the heck? Only in healthcare. Computers are supposed to make us more efficient. Right? EHR documentation takes an extra 5 minutes per patient. I've become better at it. I wrote this a year ago. 20 patients in an afternoon equals another 100 minutes of time. Policymakers and computer software programs, we've heard this throughout the week, don't understand what we as physicians do. And the individual physician in the trenches does not have a voice in the debate and is being told what to do and how to do it. The solution: recognize that health care cannot happen without the physician. Therefore, we have tremendous power if we as a group in society want to harness that power to affect change. Speak up and voice your opinion to patients, to other doctors, to administrators, to our medical societies, and to politicians. And be bold. It's okay to have fun in life once in a while and laugh over ourselves. So as Teddy Roosevelt said, speak softly and carry a big stick. Sorry. I was almost not going to put this slide in. And hear my words carefully. I'm not recommending this. I'm asking the question. What if a whole community of physicians in a small town walked away from Medicare? Not a big town. Couldn't do it in LA, couldn't do it in a big city, but a small town. I'd venture to say it would probably make the national news. The seniors would flood their elected representatives with phone calls. And they would ask, what did you do to our doctors that they don't want to take Medicare anymore? The politicians, our elected representatives, I would think, would have to come back and ask, what's the solution? How can we involve you? How can we make the system better? The very nature of the physician, it's really not in our DNA to respond like that. We take care of patients and we move on. We'd limit access to our patients. From day one of college, to medical school, to residency, to medical practice, we are all about slaying the next dragon, getting the A on the test, doing our best, and always trying to please without saying a critical word. Is like herding cats. Presenting a united front is important because when the medical profession wants to influence policy making, it is competing with a variety of interests. Hospitals and the insurance and pharmaceutical industries that find it relatively easy to speak with one voice. Well, why don't physicians unite? Doctors who try to organize their colleagues can get frustrated. This is part of the reason we're in the mess we are in today. Doctors are also busy. Quote, organized medicine can't do anything. Not a damn thing. Every time I got into a leadership position with a group of doctors, it became a complete waste of time. They weren't willing to go to battle for the things that mattered. End quote. Dr. Stephen Knope, concierge internist. And I would add to that, you heard yesterday why physicians don't unite. We have become fragmented due to specialization and subspecialization. There is no single organization that represents a majority of doctors and speaks for doctors as a whole. Physicians are busy with our practices. And physicians are hard to organize. And here was what one physician said. Thinking independently is an advantage when you're a caregiver, but it is a disadvantage when you want to present a united front. Got to go back to my roots. My grandfather was a blacksmith. My dad and uncle were iron workers. That's me. I was cutting some iron a few months ago for a building, and this thought struck me. American doctors need an acetylene torch to cut themselves free of the iron bureaucracy that is rigid like steel. The only way physicians could regain power, Dr. Knope contends, is if they resigned en masse from Medicare. Oh, there's that idea again, imagine that, is if they resigned in mass for Medicare and private insurers, forcing payers to make concessions. However, the majority of physicians have no desire to do that, and I'm not suggesting we should, it's a thought. One of the steepest barriers against physician unity is specialty identification. When physicians decide what groups to join, specialty interest comes first. Quote, physicians are more likely to belong to a specialty society than to the state medical society or the American Medical Association. And I can't read his name, Dr. Nathan Laufer, I think. I just want to read this again because I think it's important, and if you bear with me because it gets to the emotion of what I felt. This is from my op-ed piece. I don't know about other physicians, but I'm tired. I'm tired of the mandates. I'm tired of outside interference. I'm tired of anything that unnecessarily interferes with the way I practice medicine. No other profession would put up with this kind of scrutiny and coercion from outside forces. We have let nearly everyone trespass on the practice of medicine. Are we better for it? Has it improved quality? Do we have more of a voice at the table or less? Are we as physicians happier or more disgruntled than 2 years ago? 5 years ago, 10 years ago. At 58, and I am now 59, I'd likely be retired in 10 years. I was probably optimistic. It's probably less. Along with most of physicians of my generation. Once we're gone, who will speak up for our profession and the individual physician in the trenches? The politicians, our medical societies, our hospital administrators? I think not. Now's the time for physicians to say enough is enough. So physician, heal thyself. It is time for physicians to speak up for the doctor-patient relationship and the practice of medicine as we know it. Then our words need to be followed by our actions. Enough is enough. Excuse the language. To my surgeons, it is time to quit bitching at the scrub sink and be constructive. Take the ball and run with it. Walk the walk. Define ourselves in our profession, we win. Let others define us, we lose. 2 questions to finish this. Do we as a medical profession have the integrity, the fortitude, and the guts to act in unison together for the good of healthcare and for the benefit of our patients? And then final question, it is time for physicians to unite under one single organization umbrella or perhaps a coalesce of organizations and speak with one voice. Final question, who is the organization? Who are those people that will unify us? And I'll leave you with one final thought from Sir William Osler. To have striven, to have made the effort, to have been true to certain ideals, this alone is worth the struggle. Thank you very much.